early relapse, 1 to 3 prior lines of therapy, that's a scenario where we still want to be quite aggressive.
Yeah.
I will say, so at ASH, they presented, Dr. Usmani presented the CANDOR study, and that was daratumumab with carfilzomib index versus carfilzomib index. And that showed, an improvement in progression-free survival. It was not reached after about 20 months of follow-up in the daratumumab KD arm versus 16 months in the KD arm with a hazard ratio of about 0.63. And, there was better response rates in the triple versus doublet. It's happened over and over again, right? And then just recently, Dr. Philippe Moreau presented at basically the European Hematology Association meetings, virtual meetings. He presented the data from basically the IKEMA study. The IKEMA study was using isatuximab, also again with carfilzomib index, and the carfilzomib was given the 56 milligrams per meter squared twice weekly. And that one also showed, after 20 plus months of follow-up, a not reached PFS in the triplet arm versus I think 18 or 19 months in the KD arm. And that hazard ratio was 0.53, so it's a really good hazard ratio, actually.
Yeah.
So those are both of those are quite statistically, improved. And I really like the regimen of ISA KD or DARIC KD in the relapse setting. They also, with isatuximab, it's also been, like you said, combined with pomalidomide. And in the same 1 to 3 prior lines of therapy, the PFS was 11.5 months versus 6.5 months in the POM dex. And that's actually also a really good regimen. It's very well tolerated. In terms of the CD38 antibodies, where does it fit for you in terms of your therapy now? And what do you think in a year from now? Will it be frontline for everybody, and then you'll banter between one or the other? What do you think?
Yeah, well, the daratumumab is already in the upfront, right? Dara VRD, Dara RD for transplant eligible and transplant ineligible, respectively. And I did like the study with the ISA POM dex. In fact, that's an area the isatuximab is being studied also in upfront with KD and even KRD. So the 4-drug study. I think that's been done in Europe. And given the robust MRD negativity and the deepened response with VGPR or better with the CD38, yeah. It's gonna be it's probably gonna be a standard in terms of frontline therapy. Now what we're going to face with I think those once you use those, the question is in terms of once you use them as induction and then transplant or no transplant but induction and then maintenance, how long do you use the CD38 as maintenance in addition to lenalidomide? Currently, it's only 2 years, right, from the studies, but we don't know from the trials for the non-transplant eligible DARA, maintenance with len, is being used continuously. So the monthly maintenance and lenalidomide, I still have like 3 patients on that study. Even though it's completed and published, my patients are still on it and getting DARA monthly and lenalidomide monthly. Is that going to apply to patients who undergo transplants? Can DARA be given kind of continuously with, with len? But, the question, once those patients progress, hopefully after like median of 7 months, or later, but what do you give them when they've been exposed to, to a CD38? That's where the challenge will, a second class of CD38, like isatuximab, be able to overcome the refraction of daratumumab that once patient, progress. And I know there are studies looking at that, but from the publication, the study, that was published with ISA POM dex, patients exposed to DARA were excluded. I think there was only 1 patient that was exposed, but refraction to daratumumab were excluded. And patients who were exposed to pomalidomide were also excluded in that study. So it's basically patients who had no exposure to dara or pomalidomide. So that's that was the, it would be nice to see how dara fits into like the dara refractory, how ESA fits into the dara refractory line. I'm sure, you know, as time goes, they're probably going to be competing with each other as first line, in addition to the IMiD and proteasome inhibitor.
Yeah.
What do you see?
Well, see, they were actually developed based on different in vitro findings. So isatuximab was able to induce apoptosis without cross-linking, and that's why it was selected. It was the best antibody that could induce apoptosis. And that's kind of why I'm very excited with that together with carfilzomib, because I think there's synergy between the two. But we know from the IKEMA study that there's also synergy with pomalidomide for sure. Daratumumab was selected based on its ability to induce complement-dependent cytotoxicity, or CDC. So it's a little different, and it doesn't do apoptosis without cross-linking. So I do think there is a possibility that you could use one for frontline and another in the relapse setting. I do think that using one following the other within 3 months is probably not going to be successful. But if you give a 6-month break and you choose a different partner, I think that's actually fine to go back to a CD38 antibody-based therapeutic. You know, the nice thing with isatuximab, as you know, in terms of giving it, you know, the infusion-associated reaction rate's about 30 to 50%, and it's typically 1 to 2, grade 1 to 2. They don't tend to get a lot of pulmonary symptoms, which is great. We use acetaminophen, then IV dexamethasone, either 20 or 40 milligrams, whatever the regimen calls for, an H1 and H2 blocker, and give that at least for the first 3 or 4 doses. And on the package insert for ISA, you can, on the 3rd dose, you can give it over 75 minutes IV, which is really, you know, it's actually pretty convenient just to give it over 75 minutes. So at 10 milligrams per kilogram, you know, it's actually a pretty effective dose. So, you know, we're just getting that up and running here at UCSF, although we've used a ton of it in the research setting. We're getting the standard of care drug up and going.